Hey friends, welcome back to Med School Moose. In this video, we are going to be covering the chief complaint of chest pain, what you need to know, what needs to be on your differential diagnosis, what questions you need to be asking to make sure that you are crushing it on your emergency medicine away rotation. If you're brand new to my channel, my name is Masood Mohammed. I am a board-certified emergency medicine physician. I'm a faculty member at an emergency medicine residency program, which means that I work with a lot of medical students for their sub-Is and their away rotations. Recently, I posted a poll on my YouTube channel asking whether or not a series like this would be useful, and the overwhelming majority of people said yes. So that's why I created this to help medical students be successful on their emergency medicine away rotations. All that being said, this is for educational purposes only. This is not professional medical advice. Just needed to get that out of the way. And of course, be sure to subscribe to receive all of my latest videos, all the upcoming videos in this series. It is going to be awesome. Let's jump into it. So this is going to be the outline for these sub-I series videos. We're going to start with the chief complaint, and immediately we're going to jump into the differential diagnosis. This is, of course, the bread and butter in emergency medicine. This is what you're going to be asked about on your away rotation. So we're going to start right there. We're going to talk about the can't miss diagnoses that you need to know for these chief complaints, some of the lower acuity differentials, and of course, we got to throw in some of the zebras to make sure that you guys are aware of those as well. After that, we're going to go into some critical questions, and I'll explain a little bit more about that later on in the video. We'll talk about physical exam as well. We're not going to get into too much detail, just some specific points. After that, we're going to get into the workup and then some few miscellaneous pearls at the end to make sure you're getting a lot of high-yield information for these chief complaints. These videos are primarily meant for fourth-year medical students doing their emergency medicine away rotations or sub-Is, their sub-internships. That being said, the information is also great for emergency medicine interns, third-year medical students who might be doing an emergency medicine rotation, and those who are just interested in emergency medicine. All right, now let's get to chest pain. When it comes to chest pain, the differential diagnosis, for me, there's 7 can't-miss diagnoses for both emergency medicine physicians and for medical students on their away rotations. And the way that I like to break this up is there's 3 having to do with the heart, 3 having to do with the lungs, and then there's 1 other miscellaneous one. Now, before we continue, hit the pause button real quick, see if you can think of all 7 of those diagnoses, and then we're going to go through them. All right, so here they are, the 7 can't miss diagnoses for chest pain. We're going to start with the 3 having to do with the heart. That's going to be myocardial infarction, cardiac tamponade, and aortic dissection. Aortic dissection, I know technically the aorta, not technically the heart, but it fits into the list nicely, so we're going to keep it right there. So those are the 3 chest pain differential diagnoses that you need to know for the heart. When it comes to the lungs, of course, a lot of us think about pulmonary embolism. PE is one of the big ones. We also need to be thinking about pneumothorax, specifically a tension pneumothorax. That's the one that can cause really rapid deterioration of clinical condition. And then the third one there is going to be pneumonia, specifically pneumonia that's causing hypoxia, hypoxic respiratory failure, septic shock, that kind of thing. So those are the 3 can't miss differential diagnoses that have to do with the lungs when it comes to chest pain. And then the last extraneous one is going to be Boerhaave syndrome, which is having to do with the esophagus. So we've gotten the 7 can't miss diagnoses out of the way when it comes to chest pain. What are some of the lower acuity diagnoses we need to be thinking about? Well, this list isn't all inclusive, but some of the ones that I like to think about are congestive heart failure, whether that's new onset or a CHF exacerbation. Of course, some patients may come in with a CHF exacerbation and they may be very sick. They may be in cardiogenic shock, but we're going to leave this in the lower acuity category for right now. Other differentials that we need to have for chest pain, myocarditis, pericarditis. Depending who you're speaking with, myocarditis and pericarditis might exist kind of on a spectrum. They may be, 2 parts of the same condition, and that's kind of the way that I think of it too. Other differentials that we want to be thinking about, gastritis, acute pancreatitis can certainly cause epigastric abdominal pain that radiates up to the chest, so we want to keep that on our differential. Rib fractures, especially in an elderly patient, a patient that had a traumatic injury, an elderly patient that had a fall, that's something that we need to be thinking about. And costochondritis, all the way at the bottom. Really important to know, costochondritis for me is a diagnosis of exclusion. This should be the very last thing on a differential. Even if it seems like the most obvious diagnosis, even if it seems like the patient has obvious tenderness to palpation, I still want you to be thinking about all of these other higher acuity complaints when you're dealing with chest pain. So those are some of the lower acuity differentials that we need to have for chest pain. What about some of the zebras? Well, here are a few of them. Infectious endocarditis, especially in patients that have a history of IV drug use, those who had a recent valve replacement, those who had a recent dental procedure. We want to keep that high on the differential. Lung cancer, new lung cancer can certainly cause chest pain. Esophageal spasm is an interesting one. I've seen this a few times, and it can be very painful. These patients are super uncomfortable. but it can certainly be a cause of chest pain because that lower esophagus is right in that substernal portion of the chest. Shingles, of course, when you're doing a good physical exam, you want to make sure you're looking at the skin. You want to see if there's a shingles rash and that dermatomal distribution, because that could absolutely be causing chest pain. And then, of course, drug-induced is another thing that you want to be thinking about, especially with drugs like cocaine or amphetamines. These can absolutely be causes of drug-induced chest pain. All right, so now that we've broken down all the various types of differential diagnoses that we need to know, what are some of the critical questions? So I sometimes call these second-level questions or second-order questions. The first level questions being your old carts, right? The mnemonic that we all learn in medical school, the onset, the location, the duration, that kind of thing. Of course, you want to get that. That's the first level questions. Then you want to go beyond that. You want to ask some of these second level questions, these critical questions. So some of the things that we want to be asking when it comes to chest pain: does the patient have a history of similar pain? Certainly, if it's a patient that has a history of an MI and they're saying that they had pain like this when they were having their MI, that's something that's concerning. We also want to know if the chest pain is worse with exertion or better with rest, if there's any radiation of the pain down the arms, if there's any nausea or vomiting associated, if there's any diaphoresis or sweatiness associated. All four of these symptoms right here are very concerning for some type of exertional cardiac chest pain, so we really want to be asking those questions. And then another critical question that we want to be asking is if there's any ripping or tearing pain radiating to the back. Generally, we don't want to put words in our patients' mouths. We don't want to kind of feed them the answers, but a presentation like this is less common. So if you do have a patient that has chest pain radiating to the back and they're unable to describe it, you may want to ask them directly if they're experiencing a ripping or tearing pain, because that could be very concerning for something like aortic dissection. Moving on to a physical exam. Now, like I said, we're not going to go in depth with the physical exam, but a few important things that I do want to point out. If we're concerned about something like aortic dissection, if we have a patient that's hypertensive with chest pain that's radiating to the back, we want to be doing things like checking bilateral pulses, checking bilateral upper extremity blood pressures. If you're a medical student and you see a patient like this, and you come back and you tell me that you found a pulse deficit or a blood pressure differential, that's going to be very impressive. The fact that you were able to not only identify that this patient's at increased risk of aortic dissection, but you took that next step in the evaluation and you found me something that, could be very concerning, that could require an emergent workup. So that is awesome stuff to be checking on your physical exam. And of course, if you have the skills, bedside ultrasound is always a fantastic tool, especially in this area. Looking at the heart and lungs, you can see things like a pericardial effusion, poor ejection fraction, a large right ventricle, which could be concerning for a pulmonary embolism, absence of lung sliding on thoracic ultrasound, which could be concerning for something like a pneumothorax. So if you do have those skills, definitely recommend using an ultrasound to evaluate these patients. If not, go back with the resident, go back with the attending if there's time, and try to work through those skills, because ultrasound, especially in this area, can be incredibly helpful. All right, now that we've gone through the physical exam, let's talk about the rest of the workup. Of course, any of these patients with chest pain are going to be getting an EKG and a chest x-ray. That's almost a given. I have a very low threshold for ordering an ECG in these chest pain patients. Along with that, a lot of these patients are probably going to be getting a troponin, especially if they have risk factors. They're elderly, they have a history of hypertension, CAD, hyperlipidemia, diabetes, that kind of thing. And we may want to repeat that troponin if the chest pain started less than 3 hours ago. So that's an important thing to know as well. If this chest pain is concerning for something like a PE, then we may want to get a D-dimer as screening for a possible PE. And then we may also want to consider additional advanced imaging such as a CTA chest to look for a possible pulmonary embolism or aortic dissection or another concerning pathology like that. Some additional tests that we might want to be thinking about: a BNP, a brain natriuretic peptide, if we're concerned for a new onset or CHF exacerbation, and a lipase, because like I said, acute pancreatitis can sometimes present with that chest pain-like sensation. Finally, some additional pearls that I want you to be thinking about when it comes to chest pain. We should have a very low threshold to repeat concerning or abnormal ECGs. I do this all the time. If a patient comes in and I get handed an EKG and it looks like there's signs of ST depression or something else abnormal, the intervals are abnormal, or if something just looks weird, I'm going to tell whoever gave me that EKG, hey, can we please repeat this in 15 minutes and bring it back to me so that I can compare, see if there's any signs of dynamic changes, see if those ST depressions have now turned into ST elevations and now we have concern for something like a STEMI going on. So definitely if there's a concerning story or a concerning EKG, certainly reasonable to repeat that EKG just to make sure nothing's changing. Another pearl, getting an upright chest x-ray can be really helpful, especially if we're looking for something like Boerhaave syndrome that can show us signs of free air under the diaphragm, pneumomediastinum, those kinds of things can be really helpful in making the diagnosis. And then the last pearl that I want to mention is intractable chest pain really requires a cardiology consult, especially if you have a patient with a concerning cardiac history, they're having concerning chest pain, that substernal pressure-like chest pain, it feels like an elephant sitting on their chest, you've given them aspro, you've given them nitro, you've given them morphine, all of these things. If that patient's still having pain, really we need to speak to cardiology, and this patient's probably going to need to be admitted and get a cardiac cath sooner rather than later. So those are some important pearls that I want you to be thinking about. Of course, a medical student, you're probably not going to be making some of these calls, but it's certainly something that you want to be bringing up so that your resident or your attending knows that you are concerned, that you have the appropriate level of concern, that you want to do a really thorough workup and make sure you're getting the patient the help that they need. As always, thank you for watching. If you feel like you got value out of this video, leave me a like. If you have any questions, if you want to talk through any of this a little bit more, be sure to drop a comment. Click here on the left to learn 5 must-know tips for your EM away rotations, and click here on the right for another video that YouTube thinks you'll enjoy. Thank you again, and I'll catch you in the next one.